So I went to the Overdose Act. Oh, I'm Ann Livingston. I am a drug user organizer activist in British Columbia for 25 years. So we just did the Overdose Action Exchange for the third year, and it's organized by the BC Centre for Disease Control, and Mark Tyndall really chairs it, and they make an effort to bring people together from across the province. And we had the largest number of drug users there. I think this year they're really understanding they're going to have to get information from people who use drugs and get information out. And then a lot of big time experts, any provincial health, the provincial health officer, and a lot of other health officers were there. Any of the ones tasked with dealing with this in any of the 5 health authorities throughout British Columbia. So there were people from the north, the interior. There were drug users from the north, the interior, from Fraser, from Vancouver Island, and from Coastal Health. So it was a pretty well represented group. They had a methodology based on the first year, which was to take what are the urgent issues, and then they tend to say, okay, where were we last year? Let's pick up where we were. Let's say what actions we've taken, and let's move forward. So the first most urgent action in the second year, which was 2017, was to ensure involvement of people who use drugs. And ironically, this hasn't really been acted on. But I think what they've done is they've created an overdose emergency response center in the bowels of Vancouver General Hospital. There's a little bit more cohesion with who's in charge of dealing with the overdose crisis in each region. So that became more clear, which I think is good for everybody. And the depressing thing which came up over and over again was the level of overdose has not decreased anywhere in the province. So nobody's doing well. They've implemented a number of things which are super admirable, getting 54,000 overdose kits out. Shouldn't be sneezed at. That's a very important thing. They've done a death review panel of a number of the deaths from last year and got some more detailed information about the people who have died. They are starting to be really aware that this is taking place amongst a group of people who use opiates every day, even though they always keep saying, oh, they're found alone in their room and they're all men, or 80% are men. And then, of course, the Indigenous data is quite damning in that I think you're 3 times more likely to overdose if you're an opiate user and you're Aboriginal. And the women and men amongst the Aboriginal or Indigenous population overdose at the same rate, where amongst non-Aboriginal people, it's 80% men, 10% women. So it's there's stuff that's coming out, but none of it seems to be making a difference that we know it. So hopefully there's going to be more actions. I think the 2 actionable items that we were discouraged about was the people who use drugs have been meeting for many years, unfunded, and just struggling and scrapping it out with Abbotsford about bylaws, and in Surrey about being booted out of the library. And there's a lot of sort of difficult struggles that we face. Not that they've probably resulted in something, because there certainly are more and more people embracing the idea that people who use drugs are gonna have to have a role in this, or we're not gonna reduce the overdoses. Of all the actionable items, I think law enforcement and engaging peers were the 2 that are the most neglected over a period of time, where I think they were able to point to getting more people on opioid-assisted therapy, getting more overdose prevention sites opened, and the actual injection sites, which are the ones with the federal exemption. A number of them have opened. They've got mobile units in different areas. But the people who use drugs keep trying to point out that you can create a hollow OPS or a hollow, they've certainly done it with needle exchange in the past, where you go to a needle exchange and you realize they won't give out needles, even though that's what they're paid to do. And they have this kind of, what I call it, if you don't hand in some dirties, we're not going to give you any cleans, and you owe us 10 needles. And this idea that they're going to be able to do behavior modification, and that the people running these places put on airs that they're there to create that contact so they can guide you into treatment and you can become abstinent. This addiction to abstinence, or abstinent or dead stuff, still hasn't left all regions, but it's eroding. And I think we have to be optimistic, and I think a lot of work's been done. So a lot of the 7 priorities actually have action teams that are really enacting these things. So you don't get 54,000 naloxone kits out without someone working on that. So they've obviously been very successful. The places where we've had no action is the drug users have now put together, with the help of Alexis Crabtree, a proposal to say in each of the regions of British Columbia, there needs to be an office rented that's run by a drug user group within that region, that respects, is meant for that, serves them, and has a paid employee, so that there's no more of this, oh, well, does anyone know a drug user in Prince George we can invite, this, or I'm not trying to pick on Prince George, because it could be Merritt, it could be Nanaimo, it could be anywhere. Or even to say, in Vancouver, we end up with all of these sort of uncoordinated, divided groups of people that are doing various roles within what you'd call having jobs as drug users, working in OPSs, or being volunteers who were stipended, that kind of thing. So that's something that the demand is in, but as I said at the end of it, we need to have a committee. We need this accountable, and we need it measurable, and by when are we going to have it? And the other thing that came out that was very interesting was that, the very first OPS, I was certainly there, we're freezing in an alley, and it's starting to be really clear. And to his credit, I'd phone Mark Tyndall, he'd be down the next day, we'd walk around, and he started to say we need to get Dilaudid, which is hydromorphone. If we could just get the pills out, they're 35 cents a pill, they can crush them and inject them. So what is it now? Is it 2 years later? We have now a blockage, and we know what it is. The College of Pharmacists doesn't want pills to go out for that purpose because they're not meant to be injected. And we're like, are you kidding us? Like, this is, so, and the College of Physicians and Surgeons is calling it an off-use list for hydromorphone. So I don't know if the College of Physicians and Surgeons is less of a block, but the College of Pharmacists, the idea that the College of Pharmacists can block action on an overdose epidemic is beyond, I don't think anyone in British Columbia would think that's acceptable. So we started to have a sense when we were informed about why we don't have vending machines with pills out yet, even though a lot of work's gone on this thing. They've got a sense of who's prescribing where, at what time, and when it's starting. They're ready to roll when it happens. What's interesting about watching a bureaucracy with this kind of blockage by a College of Pharmacists is that the drug users, the initial breaking of the law and doing the illicit things, all we had to do is get a tent and table and start, where, you think, well, couldn't you guys just start and the College of Pharmacists can work this out later? Like, fuck you. Like, get the fuck out of it. Like, it's really alarming to think that we're going to have more dead people because some, oddly placed, we could really have a lot of criticism for the College of Pharmacists. They were sat by passively through a number of probably very wobbly stuff that they must have been aware was going on, and they didn't take any action, and now they take action to block something. It's a bit discouraging. Anyway, I'm sure I wouldn't pick on them any more than anyone else, just saying it's the one that's come up right now. So I think there's not necessarily a bad feeling, and there was no one. I noticed there wasn't people from the recovery community necessarily there, in terms of the people that are very alarmed about why are we encouraging drug use. And they seem incapable of grasping that nobody wants dead drug users on their watch. So if you're someone who's running a program and you're encouraging people to get off of drugs and become abstinent, and then you've got a high rate of overdose because people have a slip or a relapse, like I don't know what they call it. In other words, they're opiate naive, they're super high risk for this. Certainly coming out of jail is another huge risk factor. But no one seems to grasp that this is being done not to keep people on drugs forever, but to ensure that people are stable enough so that in the midst of this emergency, they can work out a way to have what you call a safe relapse, which came up with the opioid agonist therapy sessions. In the one I was in, there was recommendations that you can get on it easily, you can stay on it easily, and then if you miss a week or miss a month, like you're just lost to treatment, you can just walk right back in without doing any paperwork and get that medication right now. And that's what can save people in these relapse situations or getting out of prison situations. So They have to hear this, I think, though, from people who use drugs, and I think people who use drugs, I don't quite know what to envision next. If they obviously got a hold of places where people could inject and save people, but whether they can get a hold of medication and start making sure it's going out of these places. That's certainly the plan. To make a lot of people said, why do we have nurses sitting around at the injection sites? We don't need nurses at injection sites. Let's move things up and let's put the people in OPSs that can get prescription drugs into the places that have already got a medicalized model. They've got nurses on duty, and then open up way more places where people can just use street drugs or any drugs, and make sure that we're upping the safe supply of drugs to people who are clearly going to use these poisonous drugs and die, and keep our rates of death so high. So that's some of the stuff that the drug users network. Oh, the policing stuff. The drug users met a whole day beforehand, and they sort of were asked to come up with 3 top priorities for each of the topics that were going to be discussed the next day. And they had said more education and capacity building opportunity for peers. In a provincial way, they said they wanted peers on provincial and federal working groups. Currently, meetings dictate how peers are involved. They are not consulted nor part of the creating the event. So they want more say, not just to be brought in, oh, we have experiential people here so they can meet their quota and make themselves look politically correct. A provincial representative to assist and secure more funding. It came up too that they probably need an advocate or an ombudsperson, so that any drug user anywhere in this province can just phone an 800 number and say, I just got kicked out of an emergency ward. I'm stranded here with, you know what I mean? Anything they think is actionable in terms of saying, why have people that are drug users who have been treated badly not be able to take action on it so that it doesn't happen to another drug user? Each of these incidents, although they can seem petty maybe to a non-drug user, really puts someone at risk of scoring street drugs. If you're kicked off of your therapy, lose your meds for some reason, you're released from prison without any plan, you have nowhere to get drugs even for that one day. That's, you know, the thing people don't understand about drugs is they don't take days off if it's opiates. The other thing that came up strongly was that we can't keep ignoring it. Stimulant use, it's mixed into all kinds of drug use, and even someone who's been sort of decriminalized in the sense that they're on opiate agonist treatment and then are considered stable, they're housed, well, they're still using cocaine or crystal meth, which means they're involved in the criminal market, they're coming up with income for that, they might be dealing in order to do that. Is the whole point of it starts to be lost. So as we get opiate agonist treatment, they need to start shoving in stimulant maintenance treatment, whether it's the same physician says, well, if you're doing these drugs anyway, why don't I give them to you? Because the more we can stabilize people and keep them out of the criminal justice system and away from the criminalized street supply of drugs, the more stable they're going to become. And oddly, the more likely they are to actually become employed, reunite with their families, and even stop using drugs completely. We know those things. And it seems there's interference. The law enforcement with public health, they put that down as a part of a thing they've looked at, say, for 3 years. We have no meetings with the Vancouver Police Department. We have no meetings with the RCMP in Surrey. Most of this province is at the mercy of the RCMP. At anecdotal levels, when you talk to drug users on the ground who are really vulnerable, usually in tent cities and stuff, the police are treating them very unfairly, as are bylaw officers. So municipalities really need to be at the tables in a strong way. The people who are voting in any municipal election in British Columbia need to think, okay, the municipality I'm putting into power will pay for the police, and yet we have no information from the police. The police are refusing to give us any of their arrest statistics. So the 3 demands that came up with the peer group was the diversion program to stop arresting people for possession, petty grind, and probation and parole violations. And these are these community sentences where you're supposed to, you get released to the public you get released, and then you're supposed to report to all of these things, or you're supposed to be in a red zone, you're not allowed to go in that area. They're constantly rearrested, given more criminal charges, and re-jailed for that. And we want that ended. It's a really, really destructive practice that gets nowhere and damages people. Access to collection of data on arrests. In other words, if we ask for any of the local police forces, especially during this opiate crisis, we want to know how many heroin possession charges you've done in Vancouver, the VPD, in last month. They should give us that. And what it does is it helps keep a lid on this kind of thing so that they can hold their own officers accountable, which they don't do. We can't get any data from our local, I'll use them, pick on them, whether these other police forces give out data, I doubt. But we get them a whole year later from Statistics Canada because the police are forced to give their data to them. And then we find out that the heroin possession charges in British Columbia have actually increased during this opiate overdose crisis. And someone might think that we would have a better relationship where they would start diverting people. Oh, look, this guy's in trouble. I can see his health is terrible. Why don't I take him somewhere to get help, rather than following through with more criminal charges. So that's the kind of demand. Whether we get anywhere, we don't know. Committee of people with lived experience, police, criminology, and other local leaders. We know that we've got really good data. We've got a Cowper report update, a number of green papers or white papers or whatever colored papers, all encouraging. And now, of course, Jody Wilson-Raybould has a 300-page bill that she's going to put through that she claims will stop this over-arresting of poor, often Indigenous people who are really ill, more than they are criminals. And I don't trust that we're going to sit around waiting for a federal act to come in power that we don't even know if in the details of it it's going to help with what we want. We know there's diversion projects and they should be implemented immediately, where you've got the police saying, we're part of this team, we want these overdoses down. Clearly this person is very ill and I'm going to take them for help rather than arrest them. So that's the some of the then of course the end of that, I just said, if we don't strike this committee, we're not going to get this. And this can't be overlooked. If you live the life of a street user, you'll see their whole lives are taken up trying to dodge cops and buy illegal drugs. If we can't meet them there and make their lives better there and really intervene there, then this whole thing's just an exercise in a whole bunch of people getting career advancements due to a horrible, tragic public health emergency.